Hi, everybody. Thank you so much for joining our webinar. COVID is on everybody's mind. The vaccine is on everybody's mind. Is it effective? Isn't it effective? Israel is leading the way. And today we're very honored to have Professor Green, hails from Cape Town in South Africa, but an advisor to the Israeli government. And Israel leading the way has just so much to teach us. And is it working? Isn't it working? But Professor Green, firstly, thank you for making the time. And you're going to be interviewed by Rna Africa, a radio and TV host that does a lot of stuff for Chabad, I must tell you, and just shares goodness with the world. So I'm going to pass over to Ilana, and we look so forward to learning and hearing from you this evening.
Great.
Thank you so much, Rabbi Masinta. As we are sitting here, a few things trending in the news, and I can tell you it's not COVID-19, it's SONA 2021. The president is delivering his speech in Cape Town and talking about the way forward for South Africa. So that's what's trending at the moment. Prof, I look behind you and I see that because you are on a Zoom background, even though you're in Israel, you can actually be anywhere in the world looking at that beautiful scenic beach view behind you.
Near the beach anyway. I'm an athlete, so we've got a beach that it looks quite a lot like that.
So 40 kilometers out of Tel Aviv, we are very honored to be speaking to you tonight. One of the things that we chatted about yesterday was today's discussion, and also the fact that you don't want to position you in a place where we ask questions tonight that you might not answer. So I might as well put this out there ahead of the time. One of the SMSs you sent us is saying, just a reminder, my field is vaccines and epidemiology, not the treatment of COVID-19. But I must tell you, there's a lot of conversations around COVID-19, the vaccines, and in our environment, you are the most knowledgeable. So Professor, I'm gonna get straight into it. We know where you are, but in terms of Pfizer and also Moderna, what is the vaccine that's available in Israel at the moment?
We're using the Pfizer vaccine, although we have some Moderna. In other words, the Moderna vaccine has come a little later. We're not really using it yet because we're still using supplies of the Pfizer vaccine.
Okay, wonderful stuff. Have you had it?
I've had it, yes.
How are you feeling?
Fine. I had it quite a while ago, so I should be okay.
Do you, as someone who works in the field and especially who advises to the government, do you experiment with other vaccines?
I've worked with vaccines for many years, and I've volunteered for vaccines that have never been used, or at least are the first in humans, so to speak. Vaccines such as vaccines against Rift Valley fever, or ETEC, or leishmaniasis. So I had no problem volunteering for these trials, but I must be honest, I was generally one of the investigators in these trials, so we were expected to show an example.
Yeah. Why are we so afraid of the vaccine, if you are?
You know, in a sense, it's almost, I don't know, something that, I don't know whether you'd call it almost mystical, because actually vaccines have an extraordinary safety record. They really don't really do much harm, if any. So, you know, it's only, and certainly people who will take medications, even simple medications like aspirin, and not be worried, and then they get concerned about the vaccine, which is probably much less likely to cause any damage.
It's interesting you say that, because 2 weeks ago we had one of our medical schemes that spoke on this platform, and it was quite exciting. And one of the things he said is, we're so quick to smoke a hubbly bubbly, but when there's a vaccine, we all like, bah, we can't put this poison in our bodies.
That's right.
But I want to know how it works, also the impact of this vaccine, and also the future that this pandemic and COVID-19 holds for us. And I know that that's something that you are knowledgeable about. I know that you've prepared something for us, and I really want to see it. If you've just logged on, soon we'll also have a Q&A session. So if there's questions that you want to pose to Professor, he'll be more than happy to answer it for you. And we're available for that in the chat. Prof, what can you tell me about how this vaccine works? So let's, for instance, say it is the Pfizer vaccine, the one that we all want. I know that there's trials with Johnson & Johnson in South Africa. You know what, the news updates so quickly, and there's a lot happening. As I mentioned, SONA 21 is trending at the moment, but this morning, other things were trending. The fact that the vaccine will be available and who it will be tested on first, and as soon as this week. So what can you tell us?
Well, the Pfizer vaccine, you know, maybe I'll take one step backwards and just say, how do we make a vaccine? So the traditional technology of making vaccines is either I'll talk about basically viruses because you can have bacterial vaccines as well. But for a viral vaccine, generally speaking, we either kill the virus and we use formalin or something like formalin and inject that. And your body still recognizes as an antigen, as a foreign element, and you then develop antibodies against that virus. And then when you actually encounter the live virus, you neutralize it through various mechanisms. The other way is actually to inject what we would call a weakened virus, a live virus, but it's much weakened. And that does much the same thing. It creates, it gets into your body, it replicates a bit, and then you neutralize it. You develop antibodies and neutralize it. But then there are more advanced, or shall we say, different technologies. So the hepatitis B vaccine would be a different one where we actually produce the antigen in what we call yeast cells, same yeast that you buy for cooking. You produce it in these cells, and then you actually inject that antigen, which is part of it's a part of the virus, but your body recognizes it, and then you create antibodies against that, and you actually neutralize it. So lastly, I'll come to now, because there are others as well, and you may want to talk about the AstraZeneca, which is a slightly different technology. But the Pfizer one is a more modern technology. It's a very recent one for vaccine. And what it does basically is it actually synthetically, they produce what we call the mRNA, in other words, the blueprint for that antigen, but it's synthetic. It'll be broken down in your body, but it's put in, it gets into your immune cells. Your immune cells, which are circulating in the body, all over the body, picks it up and actually identifies it. It takes that, identifies this mRNA. The mRNA then uses the machinery in the cell. Doesn't get anywhere near your DNA, by the way. It doesn't go into the nucleus. It just goes into the area where you make things, and it makes the antigen. It makes something that looks like part of the virus, and then it excretes it. It goes out of the cell, and then the body recognizes it as a foreign antigen, develops antibodies against it, and those same antibodies will then recognize the virus. So it's a way of tricking the virus almost. So you're producing antibodies against that antigen, and when you meet the virus, you'll neutralize it. And it's been very effective. And it's a very safe procedure.
Why does it take so long to develop? I mean, I remember when COVID, when we recognized it in South Africa. So at the time, my husband was traveling and he was coming home and he said, everyone is wearing masks at the airport. You know, it's quite scary to see. And in South Africa, we were like, it's not going to come here. And then a week later, we were in lockdown. Okay. So at the time, I would think, but you know, vaccines, surely our scientists, you could help us produce these vaccines and bring this miracle drug. And then South Africa was quite disappointed because on Monday, you know, we learned about the expiration of our own vaccines, that it might be used for other uses and not for injecting because it actually doesn't work with how this virus has mutated, et cetera, et cetera. But why does it take so long to create and make?
Well, you probably know that most vaccines that we have took a long time to make, because you basically have to develop the mechanism where you will create the vaccine basically. And that vaccine has to be something that's not going to do any harm to the body, and it's going to make you produce antibodies. So there's a long process of basically identifying the way in which you can produce that. And then the next step is actually to develop ways of actually producing large quantities. So there's a manufacturing process which is not simple. For example, for the influenza virus, you need a lot of eggs. You have to produce it on eggs. So you use huge amounts of eggs, and almost that's a limiting thing. And there are new technologies now that will produce more, but that takes a long time. So there are several processes that you have to go through, and then you have to test it for safety, and you have to test whether it works, and you have to vary it, and if it doesn't work so well, then you have to go back again and you refine it and so on. But the technology now has improved. And the other thing that's helped, of course, is money. That sounds strange, but because the world was confronted with this virus and it was threatening the economies and so on, an enormous amount of funding went into it. So you can imagine, we've never encountered a situation where I think more than 200 vaccines were being developed at the same time, because it was worthwhile for companies to use it. They got $1 billion to, do some research. Why not? So it attracted the best people and the best companies, and we got them. And so we have a number of vaccines now available.
So it almost makes me think that the process in South Africa is not completely foreign, because like you mentioned, with vaccines, it's a test and trial and error. And that's the phase and stage that we are at the moment.
Sure, I think that what you've encountered with the AstraZeneca vaccine, which according to the reports, it seems to be a relatively small study, but they indicate that the efficacy, in other words, the vaccine is not working so well for mild and moderate disease, although it may work for severe disease, or it seems to work for severe disease. And that's something that's not unusual. We see it with other vaccines as the virus actually changes. I mean, that's a whole story. Why does the virus change? This is just, I'll mention on the side, this is what we call an RNA virus. Unlike we have DNA in our bodies, this is RNA. And when they replicate, they make mistakes. They don't often do it deliberately. They just make mistakes because they're not very clever. And so there are basically thousands of mutations already of this virus, but they're small mutations. The one in South Africa is one of those that's been a more significant mutation, a bigger one. And that means that it may then avoid, basically avoid the vaccine, that the AstraZeneca one, for example, and you may not be producing antibodies that are efficient enough, but that can be taken care of. I mean, you now can use the technology to produce new vaccines that will be affected with the new strains, against the new strains.
A lot of talk has gone on this week also about the expiration date of the actual vaccine. How important is an expired, does it matter?
Well, I think that I don't want to say, the company obviously has the information, and they may have tested it under different circumstances. I'm sure they did. But I think that we don't have to think that our expiration date is something that, on day X, on the 28th of March, boom, there's no longer any vaccine. It's probably a process where they may suspect that it may actually lose some efficacy, maybe because of the way in which they actually are producing it and the way in which it's kept. For example, the Pfizer one or the Moderna one has a lipid coating, which is very sensitive to temperature and so on, and movement. So these things are things that will affect it. But I would guess that you could retest the vaccines and it may have a somewhat longer usage time. And I don't think it's going to stop at one point. It might start to lose efficacy gradually.
So we've talked now and touched on how it worked, and I might as well welcome my other guests as well. Hello, if you've just joined us, we are talking about the impact of the vaccine. One of the things that most people are talking about this week is explained by our expert advisor to the Israeli government with regards to COVID treatment. We're very, very happy to have Professor Manfred Green with us tonight to chat and unpack that in the short space of time that we do have. We know now how it works, how it is created. As a scientist, as someone that has a passion for vaccines, the impact of it, because that is our discussion. So we have this vaccine available, whether it is the AstraZeneca, whether it is Pfizer or Moderna, whatever it is. What is the impact of the vaccine? What will happen once we all have it?
What you need to do, we need to talk about a couple of things, and I've got it in my slides, but I don't have to use the slides.
No, please go ahead. We'd love to see your slides.
Shall we put it up quickly?
Yeah.
Okay, so I'll put it up quickly. I'll put share screen.
So that we can talk through it, because so far we're talking about how it works. There we go. Thank you. Yeah. So we can see some.
Yeah, but you just tell me to skip things if they,
We want to see all of it. COVID-19.
Well, you stop me. You stop me. Okay, so I'll just go through a few points and then we'll come back to your question. So your question really is, how many people? Why do we have to vaccinate and so on and so forth? So if you're just looking at what's been happening here, I just want to mention that there was early in the stage, and this was something that caused a delay in our response to this pandemic, because in the early stages, I don't know whether it was happening in South Africa, professionals went through this denial process that this is not a very dangerous disease and that the virus is very simple. Now we know, as you can see, that it's much more significant than flu, for example, causing anything from 10 times more deaths than flu and probably much more. And that's the virus. It's just a very pretty virus, which I'll show you, but that's that RNA in the middle there, that coil that you see. And the spikes out there are that protein that I spoke about it uses it to attach to the cell, but basically we use that for the vaccine as well. So in most of the vaccines, they'll be very much focusing on those spikes there where your antibodies are. And this is just a quick picture that this virus actually goes into your cell It actually occupies the cell, it actually uses the material in the cell, the machinery in the cell, replicates, and then goes out with lots of little babies, and then starts going into other cells, and then obviously then destroying the cells. Just to give you an example of what's been happening in Israel and South Africa, and this is a very interesting thing. Up to now, we've had about 700,000 cases, and I see in South Africa that you've had about 1,480,000. But we've had about 5,200 deaths, and South Africa has reported 47,000 deaths. And this may be related to underlying other diseases that are around. So this may be affected by the health of the population as well. And also, I guess, treatment facilities and so on, which may differ also between the countries. This very quickly, I'll just show you this graph. What you actually see on this graph, you don't have to go into too much detail, only just focus on that black line there. And that's what we're looking at here are excess deaths during the pandemic. In other words, how many people are dying more than expected, more than we would have expected under normal deaths, normal deaths that occur. And these are the weeks down below on the axis. And you can see these small peaks there, and then the big peak here, and then there's another big peak. And those are the waves, and basically between them are the lockdowns and the restrictions and so on. We lift the restrictions, we have an increase in cases, and then we see the increase in deaths. So this just gives you a picture that we can really see the impact of the deaths. And you asked me a question about a vaccine. The idea of the vaccines is to eliminate those peaks, in other words, so that we don't have any more excess deaths. So let's just quickly go to the vaccine. You mentioned the vaccine. I'll just mention again quickly that there's the mRNA, that's the Pfizer and Moderna, that's the one that's a synthetic type, and it goes in and produces the antigen. And then the AstraZeneca uses what we call a viral vector, but it's a technology that's quite well known. The Russians have used it, and there are other companies that are using a similar one. In Israel, we're also developing a vaccine based on similar technology, using different vectors. And then the Chinese are producing and actually are using an inactivated, which is the traditional old technology. So there are a number available, and they probably, if you look at them, in the efficacy, the Pfizer and Moderna are more than 90% efficacy. In other words, they're preventing disease in 90% of the people who get the vaccine. The others are anywhere between 60 and 90%, and sometimes a little bit less. But there are a lot of what we would call fairly good or pretty good vaccines around now that can be used. So just to look at the Israel vaccination campaign, and then we can come back to some questions. We've given now about 3.7 million first doses. That's in a population of 9 million, and we haven't been vaccinating children. So that, in fact, that's 3.7 million out of about 6 million or so. So we've actually covered a large, more than half the population who were candidates for the vaccine. And already 2.3 million have received their second dose. So, so your next question probably would be the impact of the vaccine. Yes. One of the things you have to remember is that you have to give the 2 doses of the vaccine, and then you have to wait maybe a week or 10 days after the second dose before there's any impact, and that'll prevent infection. And then if you're going to measure it in cases or deaths, if we look at deaths here, if you look here, this is February, that's round about where we are now. We only started vaccinating, in December, but we gave the second dose we started to give on the 9th of January. So you actually are measuring the 9th of January, you then have to add another 10 days, which would be the 19th of January or 20th of January. And then what you need to do is to look at the fact that people will get sick. It takes, unfortunately, it takes time before people die. So we're seeing now a decline, and we actually have better data than this. And we're seeing now a very substantial decline in deaths in people who actually received the vaccine. So the vaccine is being shown in Israel now to be very effective. Actually, we have proper actual real data now, not just trial data. And this is just a number of serious cases, the same kind of thing. These are serious cases in hospital. So we are seeing already the impact of the vaccine in Israel. And we hope now that in the next month or two, we'll see a dramatic impact. We've opened up, we initially vaccinated only the elderly, I mean, not so old, but people over the age of 60. And now we dropped it to 50, and now it's pretty much open to anyone over the age of 16. And we are hoping in the future that we will be able to vaccinate children as well.
Wow.
So you want to ask a question, or should I go on for the next few slides?
You can continue, because my question is around the impact. And I mean, you just showed it to me. I've never been so jealous of anyone that has had a vaccine. I can tell you that much, because you already talked about the timeline, also the type.
Right.
I'm having a look now at Johnson's & Johnson's, just having a look at the variant that you're talking about and the type of vaccine, yes,
Right.
that it is. So immediately it gives us a classification of where we are at and how effective it will be. So I'm enjoying this. So let's keep talking, because other than the impact, I do want to know about our future. If we do have access to vaccines, what would happen to COVID in our future? Like, does it mean the disease goes away? This week, the New York Times brought out an article that talks about how this pandemic will stay with us and that it will just look differently in a few more years. So, I mean, there's a lot to be said. People are saying a lot of things around it, and I guess we just want information, Prof. So let's continue with your slides.
Okay, so I'll give you some answers, partial answers.
Right.
The point to be made all the time is that we shouldn't be too pessimistic. In other words, in the long run, we'll get out of this.
Yes.
It's not going to destroy us, but it's going to take a while to get out of it. And
Yeah.
let's just look at what's happened historically. There's only one disease, viral disease in humans, that we've actually managed to eradicate using a vaccine, and that's smallpox. So smallpox is actually the only one that we've actually managed to eliminate from the world. There's no more smallpox in the world. And we used a vaccine, and that was the last time was in 1977. So in fact, that's really, in the last 40 years, we haven't been able to eliminate any other. So that's probably a little bit disappointing. We need to just look very quickly, and I won't go through this, but I'll just go, this is a table, but you don't have to get too involved in it. I just want to show you some of the things we need in order to try and get rid of the virus, and then look at whether we think we can get rid of this this virus. So first of all, it should not have an animal host. In other words, it shouldn't occur in animals. Now we're talking about the one that's already crossed over from animals into humans, which is the coronavirus. It has been found in other animals, in mink, in cats, and so on, but in very small amounts, and it hasn't really taken root. So let's assume that it's not really in animals. So we're okay in that. We need a good vaccine with good uptake. Without the vaccine, we're not going to get there. So now we are producing good vaccine. And I'll mention it that again, it's not enough to produce a vaccine and give it to people in one country or two countries. This has to be a global effort. So in other words, if it's not globally, it's just going to remain. There shouldn't be significant mutations. Well, we can't really be too happy about that. Yes actually means that the condition is held, because smallpox didn't mutate very much. It didn't change. It's a DNA virus anyway. So this is, we are having mutations, so we may then just have to keep modifying the vaccine. So we can deal with it, but it's more complicated. We need good surveillance, in other words, good data, which we're doing. And then the other things, again, you can argue with me whether they're good or bad if you want to talk about them. Political commitment, international collaboration, strategy. These are all issues that we need to solve. But this is a time we need to use the opportunity of this pandemic to get together and show more solidarity generally, not just for COVID-19. In other words, we need to help each other more, which is something we're not doing enough of. And we should do it through the World Health Organization. So we need basically to get to something called herd immunity. And herd immunity means that there are enough people immune, usually through vaccination, but it could be through disease, to the extent that the vaccine doesn't really have anywhere to go. If you have 80% or whatever the people who already are immune, the vaccine will have difficulty transmitting because it keeps having to find someone who doesn't have antibody. So we need to get to somewhere around it. And it actually comes from the veterinary field, by the way. That's why I actually put animals. So the word herd is actually comes from the vets. And it's just the percent we need in order. And now we think we need at least 80% to be immune, and maybe in order to stop efficiently the spread of this virus. There are three diseases where we have almost eradicated them. These are polio, measles, and rubella. So polio, we thought we'd very near, but in Afghanistan and Pakistan, there are still areas where they're not vaccinating, so it still occurs there. Measles keeps coming back, although we're getting closer, I think, and there's certainly a lot less measles now than there was. And you know, in South Africa, there were huge efforts. And rubella is actually under pretty good control, and that probably will be something that we will manage as well. That's German measles. So what will happen to COVID-19? Well, let's just look at previous pandemics. So the previous pandemic, which you've probably heard about often, is the Spanish flu in 1918. Everyone, because it's the most similar in the kind of way it's going on. If you read the history of the Spanish flu and you read the reports, they behaved very much like we did. You know, trying to avoid contact and wearing masks and keeping away and so on. They just didn't have a vaccine. So this was a way in which it ran its course. There were a huge number of deaths. And then you ask me then, what happened to that virus? You know, what did it? Well, actually, it never disappeared. It actually changed. And the virus that we have, the flu that we have today, is from the virus that are descendants of that same virus. So in other words, it's still with us, the Spanish flu. But obviously now it's not a very major, for many reasons, it's not causing a huge amount of damage. I mean, it's still, flu is still a significant cause of disease and death, but not as bad as we see it was. So have any viruses, though, actually disappeared? Well, it's very unusual. We very unusually see something like that. The influenza virus in 1957 that caused the pandemic disappeared. And if you ask me why, we don't know. It went away, and we're always worried it's hiding somewhere and it's going to come back and create another pandemic, but we don't know where it went. The SARS one of 2002, which is the cousin of the SARS that we have right now in Hong Kong and that China and then in Canada and so on, that disappeared as well. And there are a couple of reasons why it did. The SARS virus of 2002-2003 was a stupid virus. Why was it stupid? Because it was very dangerous and it was killing a lot of the people that it infected. And it's not in the interest of the virus to kill you, because actually you are its home. They want to use, the virus actually wants to use you to breed and, you know, have a good life, so to speak. So here they were killing people, making them very sick. So it was easy to identify the people who were sick. And unfortunately, a lot of people died. By the way, many of the people who died in that pandemic were healthcare workers, because they didn't know that this was actually a dangerous disease. They came into the hospital, and many of the people who became ill didn't have masks and the kind of things we're using now, and they got sick. So a lot of the doctors and nurses and people, you know, the general hospital workers generally, many of them died in that pandemic. But the virus disappeared. It disappeared because you could actually isolate the patients fairly quickly and keep them out of the community. So that disappeared. And so basically, if you ask me what we think might happen, it may well be that the COVID-19 will not disappear, but it might then gradually become milder. Why it will become milder is not clear. It may be because of a change in the virus. It may be that we're adapting better, all kinds of theories. But in the long run, as I said, I'm optimistic. Nothing is actually, you know, we're in a good situation in that we have good vaccines and we'll be getting better treatment. So in the long run, I think it's going to become a disease that we'll live with. And I'll write it down quickly. We'll live with it, but it will be at a kind of a seasonal level, maybe. I just mentioned the mutations, and I guess being from South Africa, you start to recognize these numbers and letters, because the first one is the British variant, and then the next two are the South African variants. Probably even the kids now even know 484, 417, and whatever, right? You're probably hearing it on the news all the time. So these are the changes in the virus. The last couple of slides, because I know when to stop, is how long will the vaccine immunity last? Are we going to have to produce new vaccines for the new mutations, which we probably will? Will we have to repeat vaccination periodically? Probably yes. Compliance of the public with the vaccines. We need to stop this misinformation. There's a huge amount of garbage, and that's something maybe we want to talk about for a minute. Do we need to vaccinate the whole world? Yes, we really do. This is actually in the long run what we need to do. It's actually, this is the fallacy. You think that it's not occurring maybe very much in New Guinea or in Malawi and so on. It's going to get there. And in fact, the Spanish flu, very little was written about Africa in the Spanish flu. And there was an assumption that it didn't affect Africa too much. Well, it did affect Africa. They just didn't write about it because Africa was like invisible. And there was huge damage in Africa, ultimately we found. So it's everywhere. This virus doesn't care about borders. So I think it's unlikely we'll eradicate it, but you can keep it at a manageable level with good vaccines, and probably it will become a seasonal virus. And it may be the same vaccine that we'll be giving with flu. It'll even be in the same syringe. You'll go and get your flu vaccine and you'll get it with. So in the end, we need to get time, and you need to get vaccinated. And we hope you'll get the vaccines, good vaccines soon. Okay, so let's chat.
So, I mean, your slides are in depth and it answers a lot of questions. Everything from what it's called, what it could potentially do, why it's needed, why, when it is available, we need it. I think most people are also tuned into this chat because in South Africa, we are still trying to figure it out, whereas we're very jealous of people in Israel who, I mean, is it because people in Israel are used to crisis and how to react quickly when there is a pandemic or crisis upon you? Why hasn't South Africa gotten it right first time?
Well, there are a few reasons. I think you're right in saying that Israel is a country that's pretty much adapted to being going from crisis to crisis, or at least being in a semi-emergency situation much of the time. So actually, as soon as there was evidence that vaccines were available, and we have, the usual ministries of health and whoever, I guess in every country were looking around, Israel actually took a risk and actually took options on a number of vaccines. That could have been not so good because the government was spending a lot of money taking options on vaccines, and we still didn't know at that time that this disease would develop into a major disease. You remember I said in the beginning, many people were denying and saying this is just flu, it's going to go away, it's not the big deal. And here the government was spending millions and millions of dollars taking options on vaccines, which we didn't even know worked. So we had options on the Pfizer vaccine, we had options on the Moderna, and we had options on other vaccines. So we can say in retrospect that the government was very clever, but if this disease had not broken out into a pandemic, they probably would have lost their jobs because everyone would have said they'd wasted money. So in fact, it was a very good decision, but it's not an easy decision. The other, for vaccination purposes, and I guess this is where we get a little bit, you might say you get a bit jealous. We have a very good national health insurance scheme in Israel. Everybody is insured, and it doesn't matter what your income is. And there are clinics all over the country, and they call you in to be vaccinated. So you don't have to look for where you go. You already get on your phone, on your email, that you are called to get a vaccine, and I get reminders. You choose the time and the place. You go and you get your vaccine, and that's it. So that's because we have this very established health system.
Do you think it will ever leave us? I mean, we ended the slide where you said that perhaps it will be at the stage where you'd get a vaccine for flu, or you go and get your local vitamin B injection, and it might be filled with something smaller that would be able to help you overcome COVID-19.
Yeah, I think that's possible. I think that, again, when we bring it down to that level, sorry for all this talking, when you bring it down to that level, I think you can actually get to a stage, hopefully there, and maybe there will be changes in the virus because it's been circulating for so long. The virus actually, if it circulates for too long, it does mutate, as we know with the flu virus and a number of others. But it may also mutate in a kind of an adaptive way, and in other words, start to settle down to a milder illness. And hopefully that will be. But we'll need a vaccine. There's no doubt in my mind we'll have to have a vaccine, and we have to keep producing new vaccines. So anyone who works in vaccine has a good future.
I almost feel very guilty that South Africa is being held responsible for this variant, this mutation. How relevant is that? I mean, is the mutation really something that South Africans should own, or is it something that could have started in the rest of the world and been brought here?
No, first of all, we don't know. And certainly it's nothing to be embarrassed or ashamed about. The name of the virus is actually just where it's discovered. There's it doesn't mean that it was caused by that. It's circling, and there are viruses, as you know. There's the British one, and now the Kent one, and the Brazilian one, and so on. And they'll be all over the place. And that's what happens with influenza, by the way. So for influenza, for example, there was maybe you could have a Tel Aviv strain of influenza because it was first identified there. So it's really, it's just the name where they first identified. it could be that there was that it was circulating in South Africa. I don't know I don't know too much about that side of whether, because there are people, maybe there are a high number of people with immune deficiencies. In other words, their immune system is not great, and this may encourage the virus actually to replicate and then mutate. But that's just a theory. I have no idea whether that's true or not. But you'll see it everywhere. I mean, you'll see mutations occurring everywhere. The name, in fact, there's some effort. The British are trying to get rid of the name. I don't know whether you know that that the French always used to call syphilis the English disease. They said it comes from England. so this is partly a kind of a war of words between countries.
Yeah. Speaking about our countries, I'm curious because around the question of governments, and then also how you mentioned that this is a global pandemic, it feels like some countries have obtained success and then others are still struggling. Do you think that that is a power struggle between money? I mean, how come they're not vaccinating half of Israel and sending the rest to South Africa where we need it? Or do you think that we will keep it to ourselves once we have the answer or be able to solve it? Why is it so hard that when it's working in one country, in other parts of the world, it's not working?
Sadly, I must confess that this has brought out the best in us, and maybe sometimes not the best, the worst.
Correct.
And this nationalism, what we call vaccine nationalism, is certainly an issue. And if you really pushed me, I would agree with you that basically, if you have a vaccine and you have, let's say, enough for your whole population, why don't you just give some, to the most vulnerable? Let's use up 20 or 30%, give to the most vulnerable, and then share it with another country to give to their most vulnerable, and then sort of work along those lines. That's really the ideal world, which I think we should be striving for. And I think that this is an opportunity to start what we would say, taking account of ourselves and saying, shouldn't we be doing this kind of thing generally, not just here? So I think that, at the moment, it's very difficult, I guess, for countries politically even to say we're going to give away vaccine when we still don't have enough for our population. On the other hand, I think, although the World Health Organization has tried to foster that message, the World Health Organization says they formed the COVAX group, and which says, let's share the vaccines that are out there and then deal them out as people need them or as countries need them, and not just one country. We know that some countries, and Israel may well be responsible, have over-ordered. In other words, they've ordered even more than they need. So this is a real issue. So I think this is a time for us to get together. That's why I'm saying we need to talk and work out ways in which we can help each other. So I think this is something. So maybe we can start talking about Israel coming to, supporting South Africa. I would like to see that very much.
I think everyone's supporting around the world. I mean, it's not just an Israel-South Africa relationship.
Sure.
I think it's a conversation of the world, like you mentioned earlier, a global effort for all of us to try. It's interesting because it reminds me of a story in lockdown. It was probably the first week, and now everyone is realizing that there's a lockdown coming on the Wednesday or the Thursday. And I'm going off to the shops to buy milk and some bread. But I've got 2 items, and in front of me are all these housewives, and they're all pushing a big trolley. And I had 2 items, and they were like, "Don't you even try and come ahead of us and purchase your 2 items. Okay, you go right to the back of the queue." And in that same week, I'll never forget, it was in one of our townships locally in Cape Town, where a food truck had lost one of its wheels, and now there's this load with food, and people aren't allowed to go and shop because we are locked down. And everyone raided the truck. And people got a lot of criticism in the township because they raided a food truck. And I said, but there is no food and there's no jobs at the moment, and people are in lockdown. So surely selfishness takes over. And so I can see now how it started in us as humans, but we're on a global level in the world where now it's gone from food, security, money, crime, and now even vaccines, that there's a global effort for us to have conversations even around sharing your knowledge, expertise, and even vaccines to help and to heal people.
Just to add one point to that, I don't know whether it was Paul Krugman, one of the American economists, worked out that if you took all the wealth in the world, all the wealth, everything that's available, and you spread it out evenly, there would be no poverty in the world.
Wow.
In other words, there is enough wealth in the world to cover the whole population. But that, of course, means that you have to take away someone who's earning $10 billion a year or whatever these huge amounts, or 10 million or whatever they earn, and spread it to other people.
I'd like to meet them. The impact of vaccines in men and women, that's one of the things that you're passionate about. It's one of the things that you study. Just quickly, quick fire. Who are most likely to recover first, men or women?
Basically women, and that's not unusual in infectious diseases, by the way. It's an area that I've been studying for some years, and it's an area of my interest.
How do they determine it? Is it based on color or race, or because you've done it in Israel?
No, I think the men and women, it's very similar in different ethnic groups and so on. So it's not really related to race or ethnicity. Right. It's basically, women have a stronger immune system. I mean, you probably agree that women are stronger in general, but they certainly have a stronger immune system. And we do see that they do better in infectious diseases than men, almost in almost all infectious diseases. But in the COVID-19, the death rate in the cases is about at least twice as high in men than it is in women.
I had a question around, if the vaccine is available, do we take it? And I think you've said it in your slides that yes, if it's available, we take it, because that's the one way that we'll heal the world from COVID-19. But I'm just thinking, most of our attention, and especially in South Africa, we're going to need to wait for information. We're going to have to wait for a vaccine, whereas you're in Israel and you're so much further ahead in your rollout plan and where you are at. How can we keep ourselves safe? I mean, a lot of the things that are preached in South Africa is the fact that we need to sanitize, wear your mask, social distance. It's almost impossible. I was supposed to go to a camp this weekend with my children. We canceled it because I just had my little voice tell me maybe we don't go, you know. So what do we do? Because here's the thing, our focus is so much on COVID that most people are not visiting the hospital for other dreaded diseases that they have.
I think you're quite right. First of all, there are not very many options, although obviously if you're masking properly and others are masking, and this is the other thing, I mean, you know, this is another collaboration thing. Make sure that everybody's masking, and then at least in public places, I think if you're walking in the street or when going to the park, you don't have to wear a mask, in my opinion. But certainly when you're coming into contact with people, wear a mask and keep a small distance. I mean, it's not such a big deal. I think that that's you know, the point that you made about people avoiding medical care is a real point. I'll just give you 2 examples, and I'm sure it's happening. Of physician friends of mine who have told me that they've had somebody who had chest pain for 3 or 4 days and came into a hospital, you know, in a very bad condition with a heart attack that had started 3 or 4 days earlier, but was scared to come to the hospital, and somebody else who had, you know, bad bleeding and so on, and just waited. And no one should wait. And people are telling us the hospitals, by and large, and I'm sure that that's happening in South Africa as well, are pretty protected. The COVID patients are usually treated somewhat, you know, a distance away from the other patients, and they separated off. And in fact, you should, by and large, and this is what we've seen, there's no greater danger of going to a hospital than, certainly no more than the supermarket, and probably even less because people are taking much more care in the hospital. So if you go to a hospital, just about everybody's wearing a mask and everybody's distancing and all the rest of it. But that you have to get a message through to the public. They must not avoid medical care. That's one of the worries we're having, is that we're going to see, and after they're not taking care of themselves. So we're going to then see diseases and that should have been taken care of. And these people have been afraid to go to the hospitals or clinics and not going. By the way, we've even seen that with parents not taking their children to be vaccinated. And that's very worrying. So everything must be done to make sure that people feel safe to go and get medical care. That's essential.
When we started this conversation, we said the impact of the vaccine explained by our expert and advisor, and what an insightful conversation it has been so far. I mean, even in your slides, even though they were all truthful, there is a silver lining that things do get better. I think the one thing that I can take out from this, Prof, is the fact that historically we will get out of this. And then until then, we need to just stay safe, because time, I guess, is our best friend. That and God. And so if there's one thing that you can leave our global audience with, One of them being that we're going to need to start a dialogue and conversation around sharing, even if it is a vaccine. What would your message be to everyone?
You know, when the vaccine is available, take the vaccine. The vaccines are safe, and it's the only real way that we can deal with this pandemic, and we'll get out of it. And I guess what I've put in the last slide ties in with what you said. No one's safe until everyone's safe. And that just means that we need to collaborate. We need to have a world where people are working together in every area. And this is a wake-up call for us again. We're not collaborating, we're not joining hands, we're always looking for ways to argue and find conflict. We have to look at ways that we can actually be friends and work together, and we can do that, and we'll be healthier together. So we can beat it. I'm sure we can, and in the long run we will. But we need to do the work as well. We need to, we have to be part of the plan.
Well, we will be part of the solution. Professor, thank you so much. We will hear and we will do. Professor Manfred Green, all the way from Israel. I put you in the wrong position. Alit, where is it? 40 kilometers, is it from Haifa?
It's about 14 kilometers, quite close to Haifa. Yeah.
Okay.
We're in the north. We're in the north.
I almost put you in the south earlier, so.
No, that's okay. So Israel is so small that there's hardly any difference between
the north and south. Listen, I was in Yeshiva. I felt that difference very quickly from Yerushalayim to Eilat. So
exactly. Okay.
Okay, I think this is it. We're going to ask Rabbi to come back on. I think he wants
Thank
to.
you, Elana. That was great. I enjoyed
Prof,
it very much.
You're a star. You're a star.
You're the star. You're great.
Professor Green, thank you so much for taking the time.
Pleasure, David.
Absolutely.
Rabbi David.
It was outstanding to hear you. You must come back and visit home. And Ilana, you make it sound so easy. You make it sound so simple. But you're on YouTube, you're on Facebook. We send this all over the place. So thank you for making the time. We look forward to having you again.
Thank you.
Today's a new Jewish
And I want to just congratulate Chabad for all the work that you do all over the world. Unbelievable. So I want to really, you really are doing wonderful things.
I want to say as follows: tonight is a new Jewish month. There's a new month, a new moon in the air. So I want to say we should all be blessed with happiness and hope. And the ultimate blessing, Mashiach immediately will be no more pandemics and no more sickness. Thank you, Ilana.
Great.
Thank you. Thanks, Prof. Bye-bye, Rabbi.